Welcome to this episode of Orthodontics in Interview. It's my absolute pleasure to have MAZYAR MOSHIRI here joining me for this episode. So MAZYAR, welcome to Orthodontics in Summary podcast.
Thank you so much, Farooq. It's a pleasure to be here. Appreciate the invitation.
Cool. So a little bit about MAZYAR. So MAZYAR is based in St. Louis in Missouri in the Midwest in the States. He is a diplomat for the American Board of Orthodontics. He's also an assistant clinical professor in St. Louis University. He works in private practice with his father along with his sister. He's been an expert, Ask the Expert webinar with the AAO, which he's done several times. MAZYAR has spoken for the last 3 years at the American Association of Orthodontics conference. I've been following him keenly, and I'm really grateful for him to join me today so I can explore more about him, more about his clinical practice. He's also a key opinion leader for Align Technology. So, MAZYAR, thank you again for joining me today.
My pleasure. Thank you for having me.
So, I think the first question to come out, MAZYAR, is the interest in aligners. So you've been involved with setting up the intensive fellowship. You've been talking about aligners ever since I qualified and before I qualified. So what I really want to know is what led you down this aligner path?
Are you ready for a long answer? Hopefully I can make it a little bit shorter. It really is two parts. Well, I should say maybe even three that kind of led me to it. One, when I was in residency, we weren't really trained on aligners at all. I maybe had one case. And so it wasn't so much on my radar until one day before I joined my father, I made the decision to take 2 months off to basically travel around the US and visit varying orthodontic practices to see if I could just gather, some information on how to better run the business I was going to go into when I went back home. And I went and visited an alumni of the University of Louisville, which is where I went to dental school, and whose name was Dan Gurman. And at the time, Dan was one of the highest teenage providers for Invisalign in the United States. And this is back in 2008. So it was 13 years, it was 2007, excuse me. So it was 14 years ago. At that time, he was seeing roughly maybe 100 to 120 patients a day. And half of his patient population was in Invisalign. And that was mind blowing for me because I never knew such a thing could exist. And all I heard was that it didn't work. But he said, "Maz, glove up, sit down, take a look." And I was seeing, in my novice eyes at that time, what I thought were good results, in terms of what he was doing, but he was treating complex malocclusions. So at the time, that day when I was visiting with him, he had an extraction case going with TADS and Invisalign, and an orthodontic surgery case come in. So needless to say, I almost felt like I had a window into the future that I was looking through in his office, and it just really stimulated me to want to come back and add that to our practice in St. Louis. Joining with my father, he cast a very big shadow. He used to be the chairman of the department at Washington University, the ortho department. He taught at the University of Louisville for 28 years, flying in once a month to teach. So I wanted to be able to add my value to the practice, and that was one niche I figured that I could maybe add value with. And I put my head down and wanted to learn as much about aligners from that day moving forward. The latter part of that answer is that my father really is well known in St. Louis for treating a lot of TMD patients, and our temporomandibular disorder patients that we see, we always treat them with a splint first in combination with physical medicine, physical therapy. And if we're able to restore the range of motion, eliminate locking, eliminate clicking with pain, and to some extent some other symptoms that may be associated with TMD, then they're a candidate to be treated orthodontically. And many of these patients, in terms of the splint we use, they acquire a neuromuscular occlusion. It's not a postural splint by any means. It simply is a splint, is a Gelb type splint that opens up their joint space. 1 out of 10 patients, I would say, drop back. 9 out of 10 posture forward to get away from the retrodiscal tissue. And then our goal at that point in time is to then detail the occlusion to that asymptomatic position. Naturally, with a lot of these joint patients being female, and a lot of them using a removable appliance, which is a splint, many of them phase 2 were asking more and more and more, could they use Invisalign at the time? Because obviously Invisalign was doing a great job marketing themselves, and we're seeing it on TV. So we asked ourselves, why not? And we started to treat a lot of those patients with Invisalign. And unfortunately, a lot of their joint symptoms started to come back when they were on
Okay.
Invisalign. And so that basically started the beginning of a very steep learning curve, because the reason why a lot of their joint symptoms came back, a lot of these patients, because they were posturing forward, were really trapped by their bite. Either they had a narrow maxilla or a steep curvus spee or retroclined incisors or tooth size discrepancy, whatever the case may be, they were being trapped anteriorly by the bite. And that forced us to start really paying attention to all those things and over-treating them significantly in terms of over-treating them in the clin check. So bite opening, torque, really looking at tooth size discrepancy, making sure there's no interferences to the mandible coming forward and for the posterior occlusion seat. And in doing that, we noticed that we were getting much better results than what I was seeing in trying to learn about Invisalign from other instructors that were speaking at the time, because my learning curve was totally different than theirs, stemming from TMD. And so that was kind of the beginning of where my journey began and my learning, and that's how I started speaking for Align. Is that I remember sitting in the audience, and there was a speaker at the time that was saying, well, you get these posterior open bites are very common. It's because of the presence of the plastic. So just simply, section the aligner or the teeth will settle. Don't even worry about it. But in my instance, a lot of these posterior open bites were from heavy anterior interferences, and if you're pushing the condyle back in the fossa and then you're letting the occlusion settle there, you just did not do the patient a favor.
Mm-hmm.
So, I kind of raised my hand. I constantly questioned it. I went to my reps. I'm like, I don't want to hear this. This is not the right information, And then they finally said, well, why don't you talk about it? And so that was the beginning of me actually speaking for Align, which was at an AAO meeting in 2013. That I was giving a talk in their booth, and they apparently liked what they heard and wanted me to continue to speak for them, and the rest is history in terms of educating for them.
That is really interesting journey that you've been on. The fact that there was one, you weren't aware of it, you went to seek the information. Two, actually you weren't happy with what you were hearing. So you explored clinically yourself, and then now you share that information. I think that's such an interesting journey to have gone on. That's perhaps
Yeah.
really where we should be in advancing our profession, figuring out what problems we have and working out how to correct them.
Yeah.
That's really interesting. I love it. I love it. Great journey.
Thank you.
So Mars, I've seen you and heard you speak many times, and I always enjoy the biomechanics, sound, solid biomechanics. It's something that we can all relate to. If there was an international language of orthodontics, it would be the biomechanics side of it. Do you think aligners have the same versatility as fixed appliances when it comes to treating clinical cases?
No, they're more limited. It's not a perfect appliance, and certainly fixed appliances aren't a perfect appliance. But at the end of the day, what limits aligners is retention to some extent. By retention, I mean really having a firm grip on the tooth. And so when you're able to have a much more solid grip on an object you're trying to move, inherently it's going to be more effective with fixed appliances. But that doesn't mean to say that obviously there's not a place for aligners, and I think our profession is realizing that. But it depends on what the practitioner's comfort level is, and you certainly don't want to sacrifice anything. So, for example, from afar, I look at Ken Giojima treat these extraction cases, and I'm just, jaw dropping to me. And then I have not had the same success.
Yeah,
So I will not generally treat extraction cases with aligners unless it's a really, I feel like it's low hanging fruit. And low hanging fruit is somebody with an open bite tendency with severe crowding.
yeah,
Like that's a slam dunk with aligners for me and treating extractions in that type of a case. But he's doing like Bimax protrusive patients
yeah.
that have no crowding because their crowding is in the form of actual protrusiveness.
Hmm.
And I keep getting posterior open bites in those cases. And I think he's really nailed down the staging of how to control that better, because it's not just about what system you're using or what the attachments are. The staging of tooth movement is extremely important. He's mastered, I think, staging the protocol of space closure so that you don't have a lot of the iatrogenic side effects of what can happen. But to answer your first question, yeah, braces are, I think, inherently more effective, but aligners are also effective, but they're more limited, and I think inherently we all know that.
Excellent. So I suppose the next question is, with aligners perhaps only being around for the last 20 years or so, is that what do you think the next advancement is going to be within aligner technology?
I think some companies maybe have started taking steps towards this, but I do believe that maybe having different types of plastic during various types of treatment makes some sense here, because inherently the aligner is like a wire, and in fixed we use different wires to accomplish different things during treatment. It'd be nice to see that technology applied to aligners as well. And I think just doing more research, honestly, I think the biomechanics are still, while we try to reason through them cognitively, it's still vague and it's not really known. And so I think everyone's really starting to focus much more in on that. But there's so much nuance to it. It is biomechanics, but it's not the same as braces. It's not the same as fixed. So having more of a firm understanding on that, I think, is going to be really what's going to help us in the future, and helping to automate the software for us. I think what one of the negatives of treating digitally when you're fully customizing a digital appliance to a patient is that the doctor doesn't need to spend more time behind the computer. But I think we need to leverage artificial intelligence to help us with some of those decisions so we can really, at the end of the day, be orthodontists. I mean, I'd rather have a firm diagnosis in terms of, is this an extraction or non-extraction case? Do I want to do bondings on the upper, IPR on the lower? What kind of elastics do I need to run? And really let the software determine what's the staging of the tooth movement, what type of attachment does this tooth need, and help with those decisions, which really can be a waste of time, in my opinion, because it's something that can, at some point, I think, be learned, by the software. So I'm hoping that it gets to that point where we can leverage our time better and just be really the orthodontist behind the clin check or treatment plan, and not actually the technician behind the actual treatment plan, because that's more of what we're having to spend our time doing.
And that's really interesting. What you're describing there is almost how fixed appliances then developed. We had edgewise appliances, and then they became pre-adjusted. The idea was that there was less for us to do because it was inbuilt into the appliance. And perhaps that's where technology will be. It will be that pre-adjustment, but giving us those reliable results as well.
Well, that's a beautiful analogy. And I think even if you look at fixed appliances, that's already stepping into the next generation of happening in terms of even becoming more customized because of 3D printing. So it continues to advance in that direction. And I would love to see, again, that continue to happen with aligners. At the end of the day, they're still only like, really 30 years old in terms of how they've been used in our profession. It's a very young appliance, and there's still a lot of advancement that needs to happen.
I've got to ask you a question. You mentioned your father already, Farooq Moshiri, and your sister's also an orthodontist. So I've got to ask, who's the best orthodontist in that practice?
The OG is the best, for sure.
That's
Yeah,
it. Get some points.
Pops is the best orthodontist. He to be honest, he discovered this profession on his own, meaning that it was from his own volition that he chose that path. I became an orthodontist because my dad was an orthodontist.
Uh-huh.
Then my sister became an orthodontist because then we were both orthodontists. It was family business. I'm very passionate about whatever I have in front of me, but would I have chose orthodontics on my own? I'm not honestly certain about that. It may have gone a different way. Not to say that makes me better or worse, but he's 71 and he's still rocking, doing his thing. He's working with me 4 days a week right now because my sister's on maternity leave, and he genuinely loves orthodontics. He's so passionate about it. He taught for, as I mentioned, 28 years. I hope I can have the passion he does, and because I see him as being more passionate than me at his age, I'm going to give him the credit 100% for being better orthodontist.
Wow, that's amazing. Fine. I won't ask you about between you and your sister because I think we're just going to end up going just causing
Must
problems
be,
for the sake of
obviously.
it.
I'm kidding. It's a
Cool.
silly rivalry.
So well implemented. So I wanted to switch track actually. So we've had Kevin O'Brien on this podcast previously, and this year he spoke at the AAO. He gave a Saltzman lecture. And in it, he described a bit about key opinion leaders. And I just wanted to gauge your opinion on it. So he described it in his blogs previously as well, how key opinion leaders occupy an important role within our profession. But he's had some concerns over the accuracy of the information they present, some of the statements that are made, but also the amount of persuasion and influence they have over the profession without supported evidence. I've got to make sure I mention here that he did describe you in person in one of his blogs, and he said that it was a very clear lecture with no conflicts of interest and accurate information. So there is that's been said. But at the same time, there is this narrative about key opinion leaders. As a key opinion leader yourself, I really wanted to get your thoughts on what's been said previously.
Yeah, I respect what Dr. O'Brien Kevin's trying to do, and I think it's a message that does need to be heard because it's important for doctors to know that they need to filter information they hear. But at the end of the day, it's inherent in the acronym, key opinion leader. It's an opinion. So when we're up there, it's important that, we say, yeah, we're being paid for this lecture, right, that we're giving, and this is our opinion. And it's up to the orthodontist to discern what's fact or not. And in many instances, like for example, we're just talking about aligners. When I'm up there speaking about Invisalign, I can't necessarily present facts 100% because there's still a lot more research needs to be done in that area. So it is my opinion of how I achieve a clinical outcome based on the mistakes I've made historically. And that's how I try to always educate. But, and I get questions all the time when I talk. There's hands going up all the time. So I'm used to having, some type of adversity, which helps me to become better, in my opinion, when I have to be able to answer these questions to our colleagues and our peers. But to have a negative twist on what I'm doing sometimes is challenging to deal with as someone, because I want to be able to be honest. I want to be able to be truthful. Um, I was paid to give some lectures for Propel because I was using that in my office. But to be honest, I never once said it sped treatment up. I said that anecdotally, I was using it to unlock more challenging movements that I felt like were happening in terms of microosteo perforations. The patients were
Hmm.
still changing their aligners in the same fashion. I do give the vibrating mouthpieces to patients because I believe in using chewies, and I feel like that's just a better chewy to help
Hmm.
aligners seat. And it's anecdotally, I feel like their trace fit better. Could that be me kind of having confirmation bias? Who knows? But I'm very honest about it when I talk. So as long as at the end of the day, I think I have to be able to put my head down and comfortably sleep. So
Hmm.
that's just kind of where I look at the topic. I'm sure that there's others out there that are key opinion leaders that Kevin's absolutely spot on, and that we have to be very wary of what we hear. But I think the pendulum sometimes goes too far to one side where it needs to be more in the middle in terms of
Hmm.
how he's discerning us, and also how we're filtering again what we see into his message too. There's a balance there. We if you go to a university setting, the universities aren't pushing our profession forward because they don't have the resources to do so. It's people in private practice.
Yeah.
And so if the key opinion leaders were university assistant or university professors or chairmen, I'm not sure if we'd be having the same discussion about key opinion leaders, but it's just, that's the reality is they can't do that because they either don't have the resources to do so in terms of
Hmm.
where they are in the universities to develop as quickly as in terms of the change of pace of what happens in private practice, or they honestly have, more noble interests at heart in terms of what they're doing in front of the residents. But the reality is that it's private practitioners generally that are speaking. And so because of that, we do have to be, again, I think have filters in terms of what we're hearing, but also understand that they're also helping our profession quite a bit. Because without them, everything would be racing past us and we'd be stuck. Somebody has to take charge, take the lead, and take risks,
Hmm.
and as long as they're educated risks, I think that's important, but if it's just you're flying by the seat of your pants, that's when people get in trouble.
Yeah,
So.
that's really interesting. That's a really interesting opinion to have, and I think what we've seen with the key opinion leaders, and I agree with you. I think there's been some polarization that's taken place. Well, actually, from the university setting, there's always the issue of publication bias, which actually kind of seems to have gone a bit under the radar, right? So we read a publication, it's presumed fact, but actually critical appraisal of it is always a bit more challenging, and it's kind of a bit more grayer. And never received as much light as I feel key opinion leaders are at this stage. So I think there's biases in any direction that we look in, actually. It's not just the key opinion leaders, it's in publications, it's in products we read and see about. And I think we should always have that gauge as well, is this fact or not? And then it's down to the presenter to give us that information, to make the
Well, and
information.
to your point about the publication bias, there's articles come out talking about the efficacy of Invisalign. But at the end of the day, we know how nuanced it is. And so to say, for example, that Invisalign doesn't correct class twos is laughable to me. It is hilarious to me that someone would take that as being objectively fact. Because how on earth can you put two aligners in someone's mouth and wear a class two elastic and not expect that you're getting class two correction? The teeth are feeling a force. Teeth respond to force by moving. So do aligners lock the dentition up? Do they tell the osteoblasts, go to hell? No, I mean they're there and they're doing their thing, right? So um, I think again that's where the pendulum starts to swing very wildly, and people lose their middle of being, I think just thoughtful about what's happening, around them. It's just there needs to be more balance. So, aligners are extremely nuanced. They, in terms of the practitioner, a lot of the skill comes down to what the doctor's doing. A lot of the skill comes down to how you're motivating the patient, right? How well are they wearing their aligners? How are you educating them on what a properly fitting aligner looks like before they switch? Are they just switching every week because it's been a week, or are they switching because the aligner actually fits properly? What was your attachment design? Did you prioritize anchorage? Did you run your rubber bands properly? Did you diagnose for tooth size discrepancy? Did you overtreat the case enough because of the lag that's associated with certain tooth movements? I could go on and on and on and on and on. But to make that objective and to really, I think, control everything so it's appropriate, it takes the doctor out of it. And the doctor is really the biggest part of it in terms of making it successful. And so
Yep.
that's, I think, the biggest glaring, defect I see with some of the research coming out.
Yeah, I mean, so I think that was a Patterson paper from this year that looks at class twos, and I think it is an interesting one. How when it comes to fixed appliances, we always divide up research into stages. We look at either alignment, an arch wire, specific thing about it. But when it comes to lines, we're looking at the overall thing, and of course, there's so many variables there, and it's not well controlled in that process.
Mm-hmm.
But yes, and coming back onto the topic of research, actually, so you're absolutely right. The research does point towards kind of Neil Kravitz's classic paper, and his updated one as well showed us about 50% efficacy of aligners. Yet, actually, in the JCO, it spoke about aligners occupying in a questionnaire they did about 50% of the clinical practice of orthodontists. So that's Kiem's paper 2020. So how do you see this kind of this dichotomy of research says it doesn't work very well, clinical practice is increasing and increasing rapidly in use of aligners with orthodontists?
I think it goes back to what we were just talking about. Private practices evolve quicker than research does. And so, in terms of what we're doing on a day-to-day basis when we're treating case after case after case, and we have to deal with what the realities of running a practice, what patients also want at the end of the day, that we learn and we figure out how to do it. And so, a lot of the private practice doctors that use high volumes of Invisalign are getting great results with Invisalign for the most part. I can't say all of them, but I
Mhm,
would say orthodontists that I've seen, my colleagues and my peers, that I've had many people come through and take my course that they say, Mas, thank you so much, you've changed my practice life with your course, because now I'm able to treat these with much more confidence. That they had a learning process. They didn't learn that from what their Invisalign rep told them. They didn't learn it from watching necessarily CE on Invisalign's website. They learned it from taking an orthodontic course, because that's what we try to teach is orthodontics. We're doing orthodontics with Invisalign. We're not doing Invisalign, right? So we're doing
mhm, mhm,
orthodontics. So to be able to actually go through that at a university level, who's running the research? Do they have enough clinical experience to make that predictable, to really compare apples to apples?
mhm.
When you're treating a patient as a deep bite with fixed appliances and you're wiping in a reverse curve of speed, what are you really measuring at that point? And are you measuring the clinical skills of the doctor to know that they needed to wipe in a reverse curve of speed, or the efficacy of the appliance? Because the appliance by itself wasn't going to do it.
Yeah,
Something had to be done to it, right?
yeah,
Or if it needed to be segmented to do an intrusion arch, right? There's nuances to all the appliance we use, and it comes from
mhm,
clinical experience. So you can't say that plastic is garbage, metal is fantastic. It's an appliance and it takes skill. There's the art and the science to it, and so that's where I get frustrated hearing stuff like that, because there's such an advantage to having clear aligners in your practice, significant. And we all know it. I don't want to belabor all the points, but just really quickly, like three that I really focus on is one, obviously the patient experience of not having broken brackets, buttons, sores in their cheeks and so forth. Is generally speaking less uncomfortable than fixed appliances, more convenient for the patient as well, in terms of being able to see them at longer appointment intervals, in terms of what we're trying to do for them, and just overall chair time and efficiency for the practice. Because our aligner patients that come over, we really spend a lot of time with them in the first appointment going through education. It's an hour-long appointment. 20 minutes is putting on attachments, 40 minutes is talking about education. Because when I see them and I spread them out over 3 or 4 months for their appointment intervals, I want to make sure their aligner's fitting, because that makes that appointment in the chair so much easier, where I'm looking at either, am I doing IPR, or do I need to wear rubber bands? And that's really all I'm looking at. The assistant did nothing. They just checked to see if the aligner fit, and the patient's out of the chair. So that is a huge value add to a practice, to be able to level off your stress, right? And to level off the stress on your systems, on yourself, on your assistants. it's such an easy appliance to manage. It's front loaded, it's nuanced, but to have it as an adjunct is really beautiful. To have that in an office, and that's why people continue to, I think, want to do more of it, because they see the advantages of it in terms of, again, if it's giving a proper outcome, that's the number one thing. If they're confident with it, it's giving a proper outcome, that they want to do more of it because it adds so much value to, again, to the practice in terms of how to run an efficient practice, and also being able to see more patients. I think a lot of, we kind of shoot ourselves in the foot a little bit, but we're becoming, as a profession, I think, more and more efficient at doing things in terms of treatment mechanics, or again, incorporating digital technology, that we're able to actually see more patients in a day, but not necessarily increase our stress levels, which is nice. And so I think there's value to that, and clear aligners afford the opportunity to do that.
That's great. That is great. So I want to ask you more about St. Louis. So tell me, what is it that you love about St. Louis? What is the best bit?
The best thing about St. Louis is that it is extremely family oriented. It is a very family oriented city. There's a lot of things to do here with regards to just spending time with your family. A lot of things actually are even free, like our zoo is free, and it's beautiful, and they have a lot of events there. Uh, the school system here is fantastic, so it's just a great place to raise a family. Baseball is a big thing here, which is kind of interesting, but culturally, they bus you to like the baseball games in elementary school. It's a big thing. I'm sure it's like football in the UK, but
Uh-huh.
we're very passionate about our Cardinals team, which is the baseball team here. And so, every year we kind of look forward to that. There are 4 seasons here. So right now it's fall outside, so the leaves are changing colors, and so you kind of, when you grow up with that, you look forward to the changing seasons as well. So no, I love it here. My dad, because he immigrated here with my mom, late 70s, and they both got scholarships to go to dental school here. Excuse me, to residency. They had gone to dental school in Iran, so they had scholarships to go to residency here, and then the revolution broke out in Iran, and so their parents like, you can't come home. And so they stayed here, both became teachers at Washington University, which used to have a dental school at the time. And my father became chairman of the ortho department when he was a dental student.
Wow.
So when he was trying to get his US licensure, we asked him to chair the ortho department there.
Wow.
And so that was really, the writing was on the wall at that point, because that's where they ended up staying, was in St. Louis. But initially they had both gone to residency at Northwestern.
Okay.
But then when they had to understand they needed to stay here and go back to dental school, they got into WashU and went to
Fine.
school there. So, but I'm very thankful that that happened, because I'd much rather be here than in Iran. Just kind of given the opportunities that I've been afforded here. The United States is an amazing country. Very blessed to be here.
Amazing. Amazing. Miles, I just want to wrap up the interview with a final question. So, what one piece of advice would you give to the orthodontists out there?
Piece of advice. I think the most important thing for people, try not to compare yourself to others. Honestly, I think that social media is a dangerous thing, and when you're on it and you're comparing yourself to others, that can get you in trouble. I think if you put your head down, focus on delivering quality care to your patients, and just being service oriented, you'll be successful no matter what. And it's important that we be also collegial to each other. I think that there is a general lack of respect I'm seeing more universally in terms of how we communicate with each other, and it really breaks my heart. It's very saddening to me. Again, being from an era where I saw my father coming through, and how collegial he was and how professional he was, like the word professionalism. Um, I think we need to focus on that much more in terms of how we, again, treat and act with each other. So I think the overall message would be, again, focus on yourself, be ethical in terms of what you're doing, and just treat your colleagues as professionals. And I think you'll have an amazing and long career, a very happy one. But if you focus on money and keeping up with Joneses and don't treat people with respect, that's no way to go. So that's my message.
Excellent. Thank you, Miles, for joining us for Orthodontics in Summary podcast.
My pleasure.
It's been a pleasure talking to you, my friend. And for the audience out there, please to subscribe and look forward to the next episode. Thank you, Miles, again.
Thank you, Farooq.
So, Miles, I've been thinking, we've been speaking about key opinion leaders, and I think I want to become a key opinion leader.
Farooq, you couldn't even get a sponsorship for your podcast, man. I'm not sure anyone's going to really want to pay you to be a KOL if you can't even promote yourself.
Thank you,
Just
Miles.
saying. Yeah.
That's That's really really good from a colleague to a colleague. Thank you.
Sorry, man.
You're not coming back.